Bismillahirrahmanirrahim. I'm Dr. Nizamuddin Uthmani and I'm working as assistant professor in the Department of Pharmacology, Khyber Medical College, Peshawar, Pakistan. And I welcome to all of you to my channel. Today we are going to discuss one of the most important and gold standard antibiotic, that is the vancomycin. You know, Vancomycin is a very important topic, so you must listen to all these slides presentation, and you must note a few very important points, which will hardly take about 2 minutes from you whenever you are going to revise this topic. So it will be very much easy for you, especially in revision. What are the learning objectives for today? Describe the vancomycin, describe their clinical spectrum, describe their clinical uses, and then describe their adverse effect and describe their mechanism of action. Vancomycin is a gold standard for the MRSA. You all know about the MRSA. MRSA basically stands for the methicillin-resistant strain of Staphylococcus aureus. And there is another strain, what we call it the methicillin-sensitive strain of Staphylococcus aureus. There is another strain, what we call it the methicillin-resistant strain of Staphylococcus epidermidis. So we are using the MRSA, MSSA, and MREC. These four terminologies, or you can say these four abbreviations. Usually, it show the hospital environment, the hospital cleanliness, the hospital infection prevention protocols, and so many other things. In any hospital, if there is MRSA, it means there is spread of severe infection, and you can say there is multiple antibiotic resistance. So you will have to remain careful while using antibiotic in such setup where there is mostly you get the reported cases of the MRSA. But it can be used empirically for a number of diseases. Uh, it is used for the treatment of MRSA, which is in hospital-acquired infection. You know, MRSA is usually detected in the hospital, and it is usually detected in those people who are on ventilator and who develop the ventilator-associated pneumonia, who have bacteremia and septicemia because of prolonged stay in the hospital. Those who have catheter-associated urinary tract infection, those who get the Polis catheter, and those who get the silicone catheter, and they stay for a longer period of time, they usually get the MRSA. In those people who usually present in shock, and we usually pass the central line. So central line associated infection, there is MRSA. And surgical side infection, those people who get some complicated surgeries or recurrent type of surgeries, and such people, they usually develop the MRSA, and then we go to treat such people with the vancomycin. Now, there is another property of the vancomycin, that it is not absorbable from the GI tract. It doesn't absorb from the GI tract. So it can be used for those people who have the pseudomembranous colitis because of the Clostridium difficile. So those people who are using multiple antibiotics and some super sort of antibiotic and some combination of antibiotic, their normal flora of the gut get destroyed, and the Clostridium difficile infection they get developed. And such people, they develop a pseudomembranous colitis, and such type of patient can only and only be treated with those antibiotics which usually stay for longer in the GI tract. One of them is the vancomycin, and the other one is the bacitracin. So Clostridium difficile, it causes the pseudomembranous colitis, and we can use the oral. Although oral preparation of vancomycin is not available, we just use that injection. We reconstitute that in a glass of juices or in a cup of water or something like that, and we give that to the patient orally. So the vancomycin stay in the gut, destroy the Clostridium difficile, and thus they treat that pseudomembranous colitis. How you will reconstitute? Usually we get 500 milligram vial, which come in 10 ml of water. So you will mix that 500 milligram injection in 10 ml of water, and that 10 ml will then you will distribute in 4 doses. Yani, you will distribute that in 4 doses. So you will withdraw a small amount, yani 2.5 ml from that 10 ml. You will withdraw 2.5 ml, fourth dose of that reconstitution, what you have made, and then you will put that 2.5 ml and 30 ml of water. आप एक कप पानी में या एक कप juices में रखते हैं, and then you administer to the patient, and usually the pseudomembranous colitis they get improved within a few days. Now, what is the mechanism of action? Simply remember that vancomycin is a bacterial cell wall inhibitor. It's block the transpeptidase and transglycosylase enzymes, and by blocking the transpeptidase enzyme, it's blocked the synthesis of the peptidoglycan, and by blocking the transglycosylase enzyme, it's stopped the development and maturation of the cell wall. So this is the simple mechanism of the vancomycin. So it's blocked the transpeptidase and transglycosylase enzymes, and by blocking the transpeptidase, it's blocked the synthesis of peptidoglycan, and by blocking the transglycosylase enzyme, it's blocked the maturation and development of the cell wall, and thus it's make the cell wall very much fragile. And by making the cell wall fragile, there is leakage of the intracellular material, there is inflow of water, there is swelling of the bacteria, and finally there is burst of the bacteria, and they usually die. And then what is the pharmacokinetics? Creatinine clearance. You must know about the creatinine clearance level of the patient. You must do the urea and creat level, because drug is basically excreted in the kidney in the unchanged form. It is distributed throughout the body. Body weight can affect a dose. It is a highly lipophilic drug, so it's a lipid soluble. It can go to anywhere in the body. The dose is usually 15 to 20 milligram per kg of the body weight. Usually we give 500 milligram BD or 1 gram BD. 500 milligram BD or 1 gram BD. It's depend upon the weight. If the weight is below 50, you go for 500 milligram BD. Weight is above 50, this is simple, what we are using in the ward. If the weight is more than 50, you go for 1 gram BD. The drug is primarily, it is eliminated by kidney in the unchanged form, so urea creat level is must. It has got a lot of bactericidal activity, and it's depend on the inoculum. It means if the bacterial initial infection size is large, it will produce more effect. If that is small, it will produce less effect. And it has got time dependent killing, and for that time dependent killing, you keep the MIC a little bit, you keep the MIC, the concentration a little bit above the MIC. You keep its concentration very a little bit above the MIC, so you can get the desired effect. But if you keep the MIC well above, the concentration well above the MIC, there is more bactericidal killing. Now, coming to the adverse effect, it can cause the red man or the redneck syndrome. If you give infusion in a very rapid way, the person can develop allergic reaction because of the release of histamine. So we call that as a red man syndrome or redneck syndrome. The other one is the ototoxicity, and the third one is the nephrotoxicity. So these are the three common adverse effects of the vancomycin. There are two other drugs in this group. One is the daptomycin, and the other one is the telavancin. The daptomycin, again, is similar to vancomycin in mechanism of action. It inhibits the DNA as well, and it inhibits the RNA as well, and it inhibits the bacterial cell wall synthesis. So it causes the concentration dependent killing. It is metabolized by the surfactant. So we can't use the daptomycin in pneumonia, because whenever it reaches to the lung, it is metabolized by the surfactant. Telavancin is another drug in this group, and so it also causes the concentration dependent killing of the microorganism, and it's prolonged the QT interval. That's why we do not use in those patients who have some heart problem. So now, to summarize this lecture for you, I